Hello. This presentation was created for the Spring 2018 Gerontology Conference for NSG 321. The focus of this presentation will be on delirium in the hospitalized older adult. Please feel free to hit pause throughout the course of this video presentation if you need more time to read and review the slides. The content of this presentation will include the history of delirium and the definition of the syndrome. It will also go over the risks for developing delirium, the criteria for diagnosis, and the treatment of the syndrome. So, what is delirium? Delirium is a syndrome of several different causes characterized by a disturbance of consciousness with an accompanying change in cognition. While delirium is notably characterized by its acute onset, the consequences of having delirium can be long-lasting. Patients that develop delirium are at great risk for falls, long-term functional decline, and permanent cognitive impairment. Patients that develop delirium also have increased rates of mortality. These patients will have longer hospital stays and will have increased risk for prematurely needing placement at skilled nursing facilities. In 1994, the American Psychiatric Association published criteria that highlights the key characteristics and defines delirium. These criteria can be found written in the box on this slide. Delirium includes certain features such as a disturbance in consciousness with impaired ability to sustain attention, a change in level of cognition with impaired memory or disorientation, and development of perpetual disturbance that can manifest as hallucinations or delusions. Patients may have difficulty communicating with language, and the symptoms described in this box have an acute onset and cannot be explained by any other medical condition. The disturbance usually occurs over hours to days and tends to fluctuate in severity. So on this slide, there is a visual representation of the core diagnostic characteristics of delirium. So the patient that becomes delirious will have psychomotor disturbances, and this you'll see that with like repetitive, purposeless movements. They will also have emotional dysregulation. They're often irritable, angry, very anxious, and fearful that people are trying to hurt them. There's also sleep-wake cycle disturbance. A delirious patient might have their days and nights confused, and they'll be sleeping all day and up all night, being very active. Patients with delirium will also have impairment of consciousness and attention. It's nearly impossible to redirect them or sustain any attention. There is also a global disturbance of cognition. They have impairment of their abstract thinking and comprehension, and also memory impairment. This patient will be overall very disoriented, not know where they are or what time of day it is. A little bit on the history of delirium. Translated from Latin, delirium means off the track. Delirium is one of the oldest types of severe mental disorders in recorded history. Hippocrates, the father of traditional medicine, used the term lethargis, or lethargy, to describe a lack of energy and fatigue. He believed that lethargis could progress into phrenitis, or frenzy, and then back into lethargis again. This type of lethargy and frenzy cycle was often seen in ancient Greek times with relation to alcohol withdrawal. In In 25 to 50 BC, Celsus coined the term delirium and used it to describe various mental disorders and symptoms. So on this next slide, we're just going to look a little bit as to how the historical definition of delirium has changed to its modern definition. The transition of the term can be seen on this slide. Phrenitis was an inflammation of the brain accompanied by acute fever, poisoning, or trauma. And delirium went from being a way to describe a variety of mental disorders back in more historic times to now actually being a pathophysiological disorder itself in modern times. Delirium was thought to be a somatic disease by Hippocrates, but by the 20th century, it is now considered a consciousness disorder. So what is the significance of delirium in older adults? Delirium is important because it is extremely common in the hospitalized elderly. 1/3 of all older adults over the age of 70 will experience delirium. Delirium is present in 10 to 15% of older adults admitted in the emergency department. There is also a 15 to 25% rate of incidence after major surgery and a 50% rate of incidence of delirium after high-risk surgical procedures. Rates of incidence progress into higher needs of care, with more than 75% of ventilated intensive care patients and 85% of end-of-life palliative care patients developing delirium. In the United States, every year, there is more than 2.6 million older adults experiencing delirium, and it is estimated that the cost to the healthcare system is $164 billion per year for the added cost of delirium. Not only does delirium affect the patient's quality of life, but it also affects their families, local community, and national healthcare system. So there are 3 different forms of delirium. And the 3 different forms, with all their variation in clinical presentations, makes it easy for a misdiagnosis when it comes to delirium. The most recognized form of delirium is hyperactive. However, it only represents 25% of the cases. Examples of a patient suffering from hyperactive form would be one who is pulling out their intravenous catheter lines, trying to climb out of bed repeatedly. They are usually combative, restless, and agitated. Hypoactive form is known as the quiet form because it is less likely to be diagnosed and more common than hyperactive. It is noted to have higher mortality rate than hyperactive due to their inability to move, and it often is less recognized. Nearly half of hypoactive patients experience perceptual disturbances, such as aphasia or hallucinations or delusions. And last, the most frequently seen form of delirium is mixed. These patients can be very sleepy during the daytime, but at night have restless legs and trouble falling or staying asleep. And it's a fluctuation between the 2 different types. So they'll be really, really quiet and sleeping and lethargic, and then they'll progress into that very confused, trying to get out of bed, agitated state. Our next slide kind of has just another way to visualize and understand and differentiate between the 3 subtypes of delirium, and just to understand its symptomatic progression. So if you look at the hyperactive side, kind of starts with kind of more psychomotor agitation, and then increased confusion, and progresses to cognitive impairment and restlessness and agitation, and that very combative state. the patient that has an hypoactive delirium, they kind of just start as a little bit more withdrawn and kind of confused and depressed seeming, and that can progress to being lethargic and obtunded and eventually to a catatonic state. This slide is about the pathophysiology of delirium and its suggested causes. The pathophysiology of delirium is not completely understood or known. Delirium could arise from various pathways and not a single mechanism. This is an important point because this is what makes delirium so difficult to diagnose and treat. There's just so many different ways that the patient could arise at this syndrome. Some of the suggested causes include drug toxicity, inflammation, and acute stress, which all may create a neurotransmitter disruption. Neurotransmission could be inhibited by a disruption of the cholinergic system due to its vital role in cognition and attention. There is significant evidence that suggests that anticholinergic drugs can induce delirium in patients. Inflammation is also a cause supported by clinical and experimental data. Pro-inflammatory cytokines production is increased, which interferes with the neuronal communication and is followed by a seriously exaggerated inflammation response. This type of inflammation response that causes delirium is typically found following surgery or some sort of trauma or big infection. An acute stress response is associated with high levels of cortisol, which may influence or retain an occurrence of delirium. Increased levels of cortisol have been identified in post-operative patients that have delirium. Neuronal injury is also another cause of delirium in patients. So if there's some sort of ischemic or metabolic event in the brain, they are more likely to develop the syndrome. Another example is hypoxemia or hypoglycemia. They can interfere with neurotransmission, which may cause cognition and attention impairment. So, what are the risk factors for developing delirium? The risk of developing delirium increases with age, with individuals over the age of 65 being at the highest risk. Having pre-existing dementia, high levels of nitrogen-containing compounds in the blood, like high urea content or high creatinine, and other severe illnesses, including chronic neurological diseases, have been proven to be major contributors of developing delirium in the hospital setting. All of these risk factors are non-modifiable. So there's really not much we can do as nurses and clinicians to help patients with these risk factors. Clinical depression among patients also can contribute to a patient's risk of developing delirium because it weakens the mind's ability to fight off other illnesses. On this slide, we're going to talk about the modifiable risk factors. These are the risk factors that nurses can make the biggest difference in protecting their patients from developing delirium with. Actions that could weaken the mind and body's ability to fight off mental illnesses are among the major modifiable risk factors of developing delirium. Sensory impairment, mainly visual and auditory, displayed significant correlation with developing delirium in older adults. Immobilization due to restraints and catheters, as well as diminished ADL skills, tended to weaken the body's muscles in general and left patients with an increased chance of developing delirium. Mental stressors, which would include sleep deprivation and emotional distress of the patient, must not be overlooked as these increased levels of mental stress wear down and left the patient susceptible to mental illness and delirium. Another factor that cannot be overlooked is the environment in which the patient is placed. For example, patients placed in a quiet room with limited staff changes and low light at night may have a decreased chance of developing delirium than those experiencing constant environmental changes. This chart gives several suggestions on how to prevent or minimize some of the modifiable risk factors related to delirium in older adults. So, for example, with sleep deprivation, if we can reduce interruptions with scheduling of care and promoting relaxation, it can really make a big difference in reducing a patient's risk for developing the syndrome. It's also, just important to provide visual aids and to accommodate for patients with hearing impairments. We want them to be oriented in their environment, and this will really help preventing them from developing the syndrome. So, assessing for delirium. Delirium can have a widely variable presentation and is often missed and underdiagnosed as a result. It is especially difficult to assess for delirium in the older adult population due to the similar features of dementia and delirium, and the uncertainty of the patient's baseline cognitive function. By learning to properly assess for delirium in older adults, chances of functional decline decrease and better long-term outcomes increase. One of the assessment tools commonly used is the Confusion Assessment Method, or CAM. The CAM focuses on the key features of delirium: acute onset and fluctuating course, inattention, disorganized thinking, and altered level of consciousness. The CAM takes less than 5 minutes to administer and is designed to assess for the presence and severity of inattention, disorganized thinking, altered level of consciousness, disorientation, memory impairment, perceptual disturbances, psychomotor agitation, and altered sleep-wake cycle. A diagnosis of delirium, according to the CAM, requires the presence of features 1, 2, and either 3 or 4 in their tool. One limitation to CAM is that it is used to identify the presence or absence of delirium, but does not assess the severity of the condition. On our next slide, we will just take a brief look at the tool. So this is what we were talking about when I said you needed to score for 1, 2. So if you have an acute onset of a fluctuating course from their baseline and an inattention, inability to focus or keep track of what's being said, plus you either have disorganized thinking or an altered level of consciousness, then you can diagnose with delirium. The Delirium Superimposed on Dementia algorithm is a tool for bedside nurses to assess for delirium. It focuses on determining the patient's baseline cognitive function. So you're basically going to assess for dementia first before you go forward in assessing for delirium. Tools used to assess for dementia include the Mini-Cog tool, the Modified Blessed Dementia Scale, the Mini Mental State Examination, and a cognitive assessment should be completed on the admission of the patient and repeated with every change in mental status. It's also important to include the family when doing these assessments. especially in patients that don't have any medical history or diagnosis of dementia in the past. Family can be really helpful um, for helping to determine whether or not this changing cognition has been something that's been happening slowly over time or is something that's more acute to the hospital. It can often be challenging to distinguish between dementia and a delirium state. They both represent neurological abnormalities. Delirium is sudden and abrupt, as we've been talking about through this entire presentation, whereas dementia is slow and often goes unrecognized. Dementia can last months to years, whereas delirium usually lasts for one day or until it is treated. Often people with dementia are oriented to time, place, and person, and people delir- people with delirium are often disoriented to time, place, person, and people. Delirium is typically worse in the evenings, whereas dementia symptoms remain stable but can progress over time. People with dementia have recent and remote memory loss, and people with delirium often struggle with recent and immediate impairment. So now we're going to go over some of the interventions we can use to treat delirium. First, we'll be going over some of the non-pharmacological interventions. The first one is environmental. So there's this program called the Hospital Elder Life Program, which uses basic environmental strategies to reduce delirium. The environment of the patients can be easily modified by ensuring that every patient's room has a large clock, calendar, daily schedule in order for the patient to maintain continuity of their life outside the hospital. So really, it's the biggest part of this is just that orientation, always reorienting to what time and date and year they're in and where they are and why they're here. Another component of non-pharmacological interventions are kind of some of our basic care and nursing principles. There are components such as early mobilization, adequate hydration, and sleep enhancement that can really make a difference preventing delirium in patients. Studies show in order to reduce delirium, multiple prevention strategies need to be implemented. It is shown that early mobilization, hydration, and sleep enhancement have been shown to decrease delirium by about 53%. Our hospital environments are very disruptive, especially when it comes to meaningful sleep during the nighttime hours. Patient-centered care would be one that is tailored towards having the best outcomes for our individual patients. And when it comes to sleep, we as nurses should make sleep a priority for our patient. And we should examine what type of routine tasks for the patient can be done outside the normal hours of sleep. So for instance, maybe moving lab draws till after 6 in the morning, and just allowing for longer periods of sleep at night. You could look at scheduling of medications and tests and vital signs at times that would allow there to be a significant period of rest during the night. Avoiding sensory deficits can help a patient maintain control of their surroundings. By ensuring a patient has their glasses, hearing aids, and dentures, it will help the patient feel like themselves. It has been demonstrated in studies that addressing visual and hearing impairment significantly reduce the number and duration of delirium episodes in the hospitalized elderly. Delirium has been shown to be reduced by having familiar objects in place for the patient. By having items such as photographs, cushions, and a radio the patient is familiar with, the patient can feel a little bit more at home. The radio can be used to play music for the patient, which has been shown to reduce delirium. Music therapy has been proven to calm even patients with dementia and can be very calming for a patient suffering from acute delirium. Again, reorientation is key. Delirious patients are often disoriented to time, place, person, and people. Reorienting the patient to the current date, time, and recent events can help decrease the patient's recent and immediate impairment with the recent and remote memory loss. Family visiting for extended visits have been shown to help reduce delirium. Family can provide a positive environment for the patient by bringing relief, peace, and a feel of safety. Visits, however, should not hinder the patient from sleep, as delirium increases when patients do not have plenty of rest. There are a number of studies that evaluate pharmacological interventions for delirium. A study was completed using 457 patients aged 65 or older with an ICU stay. The intervention group consisted of patients to receive haloperidol intravenously and then a placebo group that received normal saline. The patients receiving the haloperidol had a significant decrease in the development of postoperative delirium, as well as decreased length of stay in the ICU. However, its route of administration by infusion dip is probably not suited for a non-research setting, and it requires constant monitoring by nurses. Another study focused on the use of olanzapine 5 milligrams that was given in the days leading up to and after surgery. The group receiving the medication had a 25.3% greater outcome of reduced delirium. However, it was found that those that did develop delirium using the medication had more severe and prolonged cases of the delirium. More research is needed on medications as preventative measures for delirium, and currently non-pharmacological methods are the current standard for care. Just some final thoughts on delirium. Delirium is a major issue plaguing the hospitalized patient. Once the onset of delirium occurs for the patient, effective treatment becomes increasingly challenging. Active prevention of delirium is the only way to ensure good outcomes for our elderly patients. By initiating multi-approach programs on all patients at risk for delirium in the hospital, we can help protect the future quality of lives of our patients. Keeping our patients oriented, moving, hydrated, and connected to their environments with the use of glasses and hearing aids can significantly reduce their risk of developing this syndrome. We as nurses need to be proactive advocates for our elderly patients and need to understand their baseline cognition and continuously reassess for changes in their level of consciousness or mentation. We thank you for viewing our presentation on delirium. Please review our references on the following slides.